Good morning, everyone. Myself, Dr. Gaoutham, studying second year radiology in Sri Lakshminarayan Institute of Medical Sciences. My topic today is about melioidosis unmasked, the radiologic chameleon with multi-organ faces. Introduction. Melioidosis is a tropical infection caused by Burkholderia pseudomallei, increasingly recognized in India and Southeast Asia, particularly among patients with diabetes, chronic kidney or liver disease, alcoholism, or steroid-induced immunosuppression. Because of its clinical and radiologic manifestations, it often mimics tuberculosis and fungal infection and malignancy, earning the name Great Mimicker. Early radiologic recognition is crucial for prompt diagnosis and targeted therapy, especially in endemic regions. Methods. A retrospective review was performed of 4 culture-proven melioidosis cases presenting to our institution over 3 months. Clinical details, risk factors, lab parameters, and imaging studies, that is ultrasound, CCT, and MRI, were analyzed. Dominant organ involvement and characteristic radiologic patterns were documented and correlated with microbiological findings and treatment outcomes. Results. All 4 patients had at least one predisposing factor, including diabetes, chronic kidney disease, chronic liver disease, or long-term steroid therapy. Imaging demonstrated a diverse organ involvement. In vascular, mycotic abdominal aortic aneurysm was seen. Genitourinary scrotal abscess was seen. Central nervous system, cervical myelitis with brainstem and cerebellar abscess was seen. Musculoskeletal, septic arthritis and osteomyelitis were seen. Spinal epidural abscess were seen. Case 1. Milioid aortic mycotic aneurysm with genitourinary involvement. A 70-year-old male with CKD and long-term steroid use presented with anorexia, weight loss, and fever. Examination revealed a pulsatile periumbilical mass and a hard left testicular swelling. Imaging and labs revealed a mycotic abdominal aortic aneurysm and abscess in the left hemiscrotum. Urine culture confirmed Burkholderia pseudomallei. The patient was managed with IV antibiotics. In the first image, we can see there is a relatively well-defined saccharine contrast-filled outpulsing with irregular margins noted arising from the posterolateral wall of the distal abdominal aorta, which is proximal to the aortic bifurcation. In the second image, there is diffuse asymmetric near circumferential non-enhancing hypotenuse wall thickening of the abdominal aorta, which is extending distal to the origin of the renal arteries up to the proximal common iliac arteries. Both these features likely represent mycotic aneurysm of the abdominal aorta. In the third image, there is a multiloculated peripherally enhancing fluid density collection, which is noted within the left hemiscrotum, likely pyoceal. Case 2. Neuromyelitis with myelitis and brain abscess. A 50-year-old female with chronic liver disease presented with fever and bilateral upper limb weakness. MRI brain showed cervical cord edema, suggesting acute myelitis. CCT brain done 2 weeks later showed ring-enhancing lesions in the brainstem and cerebellum. Cultures from blood and abscess aspirate were positive for Burkholderia pseudomallei. She responded well to antimicrobial therapy. So in this images, we can see there is extensive cord edema with long segment T1 hyperintensity, flare hyperintensity, which is noted involving the medulla, cervical medullary junction, and visualized cervical vertebra up to the C3 level. Then the cord is bulky and edematous, which is suggesting acute myelitis. In the CT images, we can see there is hypotenuse areas in the left is inferior cerebral peduncle and medulla on left side. On post-contrast images, there is peripheral enhancement, which is noted surrounding the hypotenuse areas, suggestive of cerebral abscesses. Case 3. Septic arthritis in newly diagnosed diabetic. A 37-year-old male with newly diagnosed diabetes presented with fever and left knee pain. Ultrasound revealed a suprapatellar collection with mobile internal echoes and synovial thickening. Cultures confirmed melioidosis. He was successfully treated with aspiration and IV antibiotics. In this ultrasound image, we can see there is suprapatellar collection with mobile internal echoes and there is synovial thickening, which is consistent with left knee septic arthritis. Case 4. Spinal epidural abscess due to melioidosis. A 48-year-old diabetic male presented with back pain and lower limb weakness. MRI revealed a T1, T2 isointense epidural collection from L5 to S2 with chorda equina compression. Culture from intraoperative pus confirmed Burkholderia pseudomallei. He underwent laminectomy and drainage followed by IV antibiotics and corticosteroid. So in these images, we can see there's a well-defined elongated T1, T2 isointense extramedullary collection, which is noted from L5 to S2 level, displacing the chorda equina nerve roots anteriorly and causing secondary canal narrowing at L5, S1 and S1, S2 levels. Discussion. Melioidosis can present with vascular, genitourinary, venous, musculoskeletal, and spinal manifestations that closely resemble more common infectious or neoplastic conditions, posing a diagnostic challenge. Recognition of specific imaging pattern in patients from endemic regions with compatible risk factors should prompt consideration of melioidosis and request for targeted microbiological testing. I-10 radiologist awareness can facilitate early diagnosis, timely initiation of therapy, and improved patient outcomes. These are my references. Thank you.